All right, so we are live. Hello, everybody. Thank you so much for joining us. Come on in, get settled. We have an awesome panel set up here for you today. We hope you enjoyed our morning sessions this morning. Thank you for joining. So before we get started, I would just like to give a quick shout out to our corporate partners and our individual donors. Thank you so much for your support and for making this program possible for all of us today. So we have an expert panel set up for you today. I'm really excited. We have Dr. Jennifer DeSimone with Inova Schar Cancer Institute. We have Dr. David Fisher with the Dana Farber Cancer Institute. He'll be joining us in just a minute here. And we have Dr. Yvette Kasamon. She is with the Center for Drug Evaluation and Research, FDA, and Dr. Ellen Kim with the Perelman School of Medicine. So thank you all so much for being here with us. We're really excited. This is going to be just an open Q&A format, really informal here. We want to make sure we get all of the questions answered for you that you came here with. So at the bottom of your screen, there is a chat section, and during this panel, you can just type in any question you have, and I'll ask it aloud for you. It can be very anonymous, very private. Since we don't have cameras turned on, ask anything you'd like, and we will hope to get all of the questions asked for you as time allows. So let's see, we're going to start off with a couple questions that were submitted ahead of time, and folks just feel free to type them in as we go along. So the first question was, how certain is my diagnosis? Could there have been a mistake? So I don't know, let's see, Dr. Kim, do you want to take this one?
Yeah, certainly. So I think that's the hope of every patient, that maybe there was a mistake, or perhaps it's something else. And I think as physicians, we certainly, for patients who have cutaneous lymphoma where the rash is sort of nonspecific looking, we want to keep an open mind. I know that when I meet patients for the first time who are referred, we do go through a list of questions just to make sure it's not a rash that's mimicking cutaneous lymphoma. So we ask about medications started before the rash, any new sort of contacts, topical things you might have started using. Sometimes connective tissue disease like lupus, morphea can also mimic cutaneous lymphoma. So it is, when you go to a specialty center and you have an experienced doctor, they will always keep that in the back of their mind, and you should always speak up to and ask that question.
Great, thank you. Let's see, our next question is for Dr. DeSimone. It says, Dr. DeSimone, you mentioned something very briefly about HCTZ and CTCL. Since I have been taking HCTZ, and I'm sorry if that's an abbreviation, I don't know what that is, for years, I want to hear more.
Sure. So HCTZ stands for hydrochlorothiazide, which is a diuretic that's used in the management of high blood pressure. And it's a drug that has been shown to cause quite a few problems in the skin. One of them is an association, not a definite cause and effect relationship, but an association with mycosis fungoides. So in my patients who are on that, I do routinely communicate with their primary care doctors and try to get them on another regimen of drugs to manage their hypertension that excludes HCTZ and other thiazide diuretics, just because I've found that it's very helpful in being able to get better disease control. And if there is some modification in terms of how the lymphocytes in your skin are working, if there's some lowered threshold from a drug effect that's causing you to have some dysregulation there that's resulting in your mycosis fungoides, we want to remove any possible triggers that might be in play. So particularly with patients who have greater than stage 1B, or in whom I'm not able to get great control with topical therapies, I definitely try and get them off of that.
Okay, great, thank you. Anybody else have anything to add? Nope. All right. The next question is, my 29-year-old daughter was just told she's at patch stage. What does that mean? Anybody willing to take this one?
I can take that. Ellen, let me know if you'd like to join in. But basically, when we talk about true staging, it should be a numeric system, an alphanumeric system. But some people do refer to the stage based on the morphology or how the skin lesions look. And so patch is kind of the very early, very thin, not much projection or depth to it, scaly phase that precedes any possible development into a plaque, which would be a thicker, more raised lesion, or a tumor. So patch stage is by far the most common form of mycosis fungoides. It's the easiest to treat, and it, in general, it has a pretty good prognosis.
Okay. Anything to add, Ellen?
I would just say that some people have a few patches and some people have many, many patches. And for early stage disease, patches are plaques less than 10% of your body's stage 1A, and between 10% and 80% is 1B. So there can be quite a range of body surface area. And those stages usually imply there's nothing internally, so nothing in the lymph nodes, blood, or internal organs.
Okay. And Dr. David Fisher is here with us as well. Hi, Dr. Fisher. Thanks for being here.
Hi, thank you.
And feel free to chime in here. It's just a very open Q&A format here. So I'm just asking the questions aloud, and whoever is willing to answer it can take it. Let's see. So the next one, even in an early stage like mycosis fungoides stage 1A, how much is my immune system compromised? And then it says, second part, how about in terms of the coronavirus?
So I'm also comfortable taking this question because it comes up very frequently, multiple times per day, and it's a very good question. Patients understand that mycosis fungoides involves your T cells, part of your immune system. So the natural question is, well, am I immunosuppressed and am I at risk for infectious disease? So the way that I counsel my patients is that, especially in stage 1A disease, you have a focal dysregulation of your skin only T cells, which does not necessarily impact your respiratory immunoglobulin production or your systemic immune function in terms of being able to clear viruses. So I really try to reassure my patients with stage 1A mycosis fungoides who are concerned about immunodysregulation that's on the systemic level. I don't think that that is anything that we really need to be concerned about.
Okay. Let's see, another stage 1A question. What does the research say about mycosis fungoides and pregnancy? Does the disease present any risk in pregnancy, and does it pose any risk to me as the patient or the baby?
I can try to tackle this, and others can chime in. So as for early stage disease, as far as we know, it's reassuring that it should not. I've had a number of early stage female patients who went through pregnancy without an issue. There are a few considerations for early stage, is that we want to make sure that the treatments that you're on, whether it's skin-directed therapies or internal therapies, that you have a conversation with your doctor and your obstetrician about the safety during all trimesters of the pregnancy. So if you're planning to have a child, it's important to start that conversation early so that we can come up with the best plan to treat and or monitor your disease safely. I think for patients who have more advanced stage disease, then we do like to get certain types of obstetricians involved. Sometimes we call them high-risk obstetricians, to check in with them, and they might follow you more closely. I think the chance of mycosis fungoides, even in those patients, spreading to the baby is exceedingly low, if not zero, but then patients do merit being monitored. But for early stage, I think that just make sure you talk with your doctors, but it should not be an issue.
Okay. Dr. Fisher, anything to add?
I think that for more advanced stage disease, when you're using chemotherapy agents, then that can be trickier for the pregnant woman, of course, particularly the first trimester. Once you get to the late second and third trimester, many chemotherapies actually are relatively safe for the baby. Hopefully, those paths don't cross very often.
Cool. Okay. Next one, I have LYP taking methotrexate 10 milligrams a day. Does LYP affect your body's ability to regulate heat? Anybody want to take this one? Dr. DeSimone?
Sure. Not that I'm aware of, and especially in mild to moderate cases of LYP where you've got, let's say, less than 100 lesions at any given time. That's not something that I've experienced with my patients, but perhaps others have different experience.
Okay. Anybody else have any experience with that with their patients or anything to add?
I guess I would want just to confirm it's 10 milligrams a day, or the more typical dose is once a week for LYP, which is a very, very low dose. I think methotrexate 10 milligrams daily every day. I would say that maybe if the person who wrote the questions having some body temperature concerns or side effects, maybe discuss that with their doctor.
Mm-hmm.
But I agree with Dr. DeSimone that lymphomatoid papulosis, typically feeling cold or having temper dysregulation is not a common symptom. I guess that if your LYP lesions get secondarily infected, sometimes they do with bacterial infection or cellulitis, then you might have temperature dysregulation. But it's a little different than mycosis fungoides patients. Mycosis fungoides patients who are erythrodermic, red all over, they often have temperature dysregulation.
Okay. Let's see. Stage 2B, having phototherapy, spot radiation for tumors, and bexerotene. What should be next if tumor growth continues?
I think that's a very individualized question. There are multiple agents that would be appropriate in that scenario, but your physician should sit down with you and take into account any other illnesses that you might have in the background that might make one agent a better choice over another. The regimen that you're on now sounds fine, but if you find that you're having progression of disease, there certainly are many other choices that might be appropriate for you. But it's hard to say without knowing the complexity of you as a person, what one path would be the best to go down.
Okay, I'm seeing shaking heads, so it looks like you concur.
Yeah, that's one of the things about treating MF. I like to think of this as each patient is unique, and luckily we do have many therapies in our toolkit, and so it does require an overall and holistic approach to treating each patient. I would just add that radiation therapy is certainly very, very important for tumor stage disease, and we continue to, I think, use it throughout the course of a tumor stage patient, whether it's the primary therapy or in combination with internal therapies. And as maybe some of you know in the audience, there's different forms of radiation. These days we're doing a lot of low dose radiation, which is 2 or 3 days worth, which allows us to continue it over and over again if we need to.
Okay.
And just from the chemotherapy standpoint, again, it's very individualistic. Does the tumor express CD30, in which case we might think of a drug like brentuximab, which targets that protein. Then there are other agents, and depends on what medications the patient may be on, whether diseases they may have. So it is, as been mentioned, very individualized.
Okay, thank you. Let's see, does exercise or any sort of excess sweating agitate mycosis fungoides, including progressing the disease, or does sweating simply increase blood flow to the skin, making it appear as if it's getting worse?
I have that question asked sometimes in clinic, and basically what's happening when you exercise is you're raising your core body temperature, and then your body needs to release that excess heat, and so you sweat, but you also shunt a lot of your blood in general toward your skin. So anything that's inflammatory in the skin in the background is going to become more pronounced once you increase the blood flow to the skin. And that's why even after a hot shower, patients will describe that some of their patches or plaques look much more red than they do at rest or right after waking up. But there's no evidence that exercise is going to cause progression of disease, and I think exercise is very important.
Okay. Let's see, is there a relationship between mycosis fungoides and COVID-19? do you think COVID could drive the disease into the internal organs of lymph nodes? If you get COVID, do you think it would be more severe with this disease?
I guess maybe I could take that one since I hear this question every day in clinic. I don't think that COVID makes the disease worse or has a causative component. I don't think the incidence seems to have changed since COVID. The big question that people ask is whether they're more likely to be infected or have more complications. I think likelihood of infection really has to do with exposure. So I don't think that's so much affected by the disease either. Side effects, complications, tolerance of the infection certainly can be affected by your immune status. And that varies considerably, as we've discussed, amongst our patients, whether they have early stage disease and are on minimal therapy, or whether they have advanced stage disease and are on aggressive chemotherapy. Certainly, patients on aggressive chemotherapy, their immune system is weaker, so theoretically it would be harder to combat COVID-19. The one complication of COVID-19 seems to be an overreactive immune response, which maybe a blunted immune system is a little better. There have been differing reports on whether blood cancers, patients with blood cancers have a worse outcome with COVID-19, and the results have been mixed. But I would certainly encourage patients to do everything they can to avoid it.
Let's see. Susan, I think you had another question that was asked.
Yeah, so, and I'm going to address this to Dr. Kasamon from our guest from the FDA. Just maybe in general, I know a lot of folks watch the news and are concerned, and you may or may not be able to address different pieces of this, but you know, we've got a lot of clinical trials going on, and there's different things. How do we ask the question? You probably can't even answer it really that I know, but maybe based on what you can address with regards to COVID and the impact on the FDA. Obviously, a lot of focus has been on what's happening in clinical trials for vaccines and the virus and so forth. You know, anything that you might be able to share from your perspective and the perspective of CDER, how COVID has impacted and what some things are happening that we might be aware of or might impact us as a small rare disease organization or group of patients.
You know, so I can speak to what's happening within our division that is focused on reviewing drugs for patients with cancers, and in my group specifically for patients with lymphoma, and we really have not allowed the COVID pandemic to affect our internal timelines for reviewing drugs. If a drug has priority review for a marketing application, it's a priority review, and we take those deadlines, those goal dates, very seriously. Without wiggle room, and so we've had quite a number of research applications, asking questions about, how to treat, COVID. And some of those applications we've been tasked with reviewing. I can't speak to any specifics, of course, but what I can say is that we have developed our own very expedited timeline for reviewing these. So never mind the 30-day window, when we have a new investigational drug application. We're committed to reviewing those applications even more quickly, oftentimes involving more than one discipline. So it might be a discipline that has expertise in treatment of viruses, or a discipline that might have expertise in treating cardiac and pulmonary disorders. And oftentimes we will work in concert to really, really step up the review timeline even more than we already do. So, in terms of, our typical, review timeline for marketing, for marketing applications, we have not allowed the COVID pandemic to affect that. And in fact, you'll see as time goes on that oftentimes we'll actually complete reviews and issue approvals even before the deadlines for a priority review. So, we've been dedicated to our mission, to protect the public health and base all of our decisions on the safety and effectiveness of the drug based on studies that we have available at the time. And we know that we're in a political environment. Nobody can refute that, and we know that these are obviously very difficult times. But we've stayed true to our mission.
Great, thank you. And I really appreciate you, again, taking the time to join us and to
My pleasure.
participate, because I think, especially in our rare disease arena, it's not every day everybody gets to exposure to somebody from the FDA. I have the luxury of participating in a lot of the events and bringing our patient voice to the table at the FDA and to be part of that. But I really appreciate your ability to come and chat with everybody and to share your knowledge. And, I hope that we'll be able to do more to educate folks on what the FDA does and how it does it. Because I know for me, it's been quite an educational experience over the last 9 years that I've had the ability to learn more and to see how things function and learn all the different institutes. And, it's complicated, but you guys do an amazing job. And I just wanted to say thank you.
Well, thank you. We're privileged to have been invited to this session, and and this sort of outreach, both to the scientific community as well as to patients and their family members, is a vital part of what we do, and it's one of our important missions. So thank you.
Thanks, Dr. Kasamon. Let's see, our next question. It says, I've been on HCTZ with Triamterene for over 30 years for edema. Should I be concerned?
I think because I brought this up earlier, I'll grab it, but I think it depends on how well controlled your disease is. If you've been unable to gain decent disease control during this time frame, then you may want to look at removing a possible trigger, which would be HCTZ. So it really depends on what the status of your disease control is. And you can feel free to bring it up with your primary care doc to see if there's anything that could be swapped out if it's necessary. May not be. Again, it's not a cause and effect relationship. It's a loose association.
Okay. Let's see. I have MF1A. What should be done to maximize the likelihood that I will remain at that level? Sort of keeping the thing. Dr. Kim, do you want to take this one?
Certainly. So that's a very common question, especially when you're first diagnosed. And I would say that most patients do ask about things like diet or supplements or anything additionally they can do. And we don't really have the studies or data to suggest there's a special diet or supplement or any other thing to do or actually to avoid, except for standard common sense general medical recommendations. So a healthy diet, exercise, taking care of mental well-being, keeping up to date with your age-appropriate vaccines and age-appropriate cancer screenings. Those are all things that I think sometimes even myself, we sometimes let go by the wayside. And I think when you get a diagnosis of a cancer or a chronic medical condition, then it's good to kind of refocus on those basic but very important things.
And we also had another question, which kind of goes with that one, that said, do you advise your patients change their nutrition or diet? So you already kind of addressed that. And they just asked if you found any correlation with certain foods or alcohol on the progression of the disease.
Not big, well-run studies.
Mm-hmm. Okay.
I think one of the difficulties is that in the lay press and public, you often get information from different websites or certain lifestyle folks who might say, this is an anti-cancer diet, please, pursue that. We don't really have data to say that. So I would mostly, try to be common sense about it and follow the standard recommendations. And I hope someday we have more information about something special we can do, but it is pretty basic.
Mm-hmm. Okay. Dr. Fisher, I see you nodding. Anything to add?
No, I think that's good advice. Healthy, balanced diet, exercise, pay attention to the rest of your health. For 1A patients, they have very good prognoses. And so don't forget about the rest of the health that could be much more limiting.
Okay, thank you. Let's see. For targeted therapies, how do you find out whether CD30, CCR4, etc.?
So there are basic immunohistochemistry tests that are done on tissue. You can also analyze blood and nodal tissue that look for the presence of specific markers. So it could be as easy as your skin biopsy being sent for additional analysis.
Let's see. Somebody asked, could fatty cysts be MF? Anybody?
I imagine that you're referring to lipomas or fatty cysts underneath the skin. That's unlikely, not impossible, but unlikely to be related to mycosis fungoides, which usually originates from the top layer of skin, the epidermis or the dermis. So if you've got something that's deep under the skin, has been stable for many years, is soft and squishy and doesn't hurt, that's probably a benign lipoma.
Okay. Let's see. Other than general itching and the lesions on the skin, are there any other general symptoms associated with MF? Kind of a tough one.
Yeah.
Dr. Kim?
Well, there can be other symptoms. I guess most of the time we talk about it by stage or lesion type. So early stage 1A patients often have no symptoms. I would say half of my patients aren't even very itchy. Just the skin is discolored, blotchy, and dry. I do think itching is the most common symptom. It can range from mild to completely severe and debilitating. Some patients have more sensitivity of the skin, like a chapped feeling rather than itch. And then you can get cracks in the skin, and then that can be very painful, particularly if it's on the hands and feet. It makes it hard to use your hands in doing things. And then I think for more advanced stage patients, they can have, more symptoms depending on the types of skin lesions and extent of involvement. Patients may feel tired from the disease. Leg swelling is very common in patients with what we call erythroderma, and pain in patients who have tumors that are open, have open sores on top. Those are the symptoms for the more advanced patients.
Okay. Let's see. Can scalp seborrheic dermatitis be related to CTCL?
I don't think that it's related. So seborrheic dermatitis is basically inflammatory dandruff. It's very common. So it may be totally incidental that a patient has both, but it's important to make sure that you're not overlooking patches of MF that may be present on the face or scalp and dismissing them as seborrheic dermatitis when they may in fact be, lymphocyte dyscrasias or MF. But I don't think that they're pathophysiologically linked.
Okay. Let's see. A previous webinar mentioned that vaccines with live viruses should be avoided. Are pneumonia, shingles, annual flu viruses safe? And what vaccines are not safe for MF patients? Get a lot of vaccine questions.
Yeah, maybe I can take that since I spoke about it before. So the short answer is yes, the three that were first mentioned. The newest shingles vaccine The flu shot that's given as an injection and the pneumonia vaccine are inactivated and are safe. There are the live vaccines that are most common, but not very common for MF adult patients. There's flu mist, which is inhaled, that's live, so you want to avoid that. And the older version of the shingles vaccine was live. And then yellow fever, and there's some other vaccines for travelers. I think that just like with anything, so for live vaccines for people who travel internationally, it really depends on the stage of disease and then where you're traveling. So everything, the doctors, you might hear, we say this term risk-benefit ratio. So I have some early stage 1A patients who have like 1 or 2 patches and they're going to go travel to Southeast Asia, then I will tell them to get the live virus vaccine to prevent infection. But then I tell them to go talk to the occupational health or travel medicine person. So it's not always black and white with live vaccines, but in general, we have a good option. There are many inactivated vaccines now, so that's definitely safe for all stages.
Okay. Let's see. Related to itching or to itch, have you had patients describe a sort of pins and needles feeling like numbing on the skin? And what do you advise for addressing that?
I definitely have had patients describe, stinging, pinprick-like discomfort, so that doesn't sound unusual. I think you have to try and treat the underlying cause. So we know that it's probably the dense inflammation in the skin that's creating the nerves, creating the nerve triggering there, and that's what's causing all the symptoms. So I try to use as much therapy as I can to decrease the amount of inflammation in the skin and thereby hopefully ameliorating the symptoms. I try to get to the root of the problem, because the other things that you use for symptomatic management are basically just layered on after the fact and aren't really going to get to the underlying cause of the problem or give you good long-lasting relief.
Okay. Anything to add, anybody? Nope. Okay, let's see. This person said, I have the opportunity to participate in a COVID vaccine trial. I am 72 years old and have had MF stage 1B for 4 years, controlled with intermittent UVB light box and topicals. Okay, I don't know if that was maybe is that a good idea kind of question? If they should participate in the vaccine trial, or if it...
Well, the stage 1B is quite a spectrum within itself. There are some patients with stage 1B and if you're very well controlled on such therapy, it might be reasonable, but many clinical trials do, they're kind of strict about what we call other conditions. And so they may exclude patients who have a history of any cancer. So I guess that would be something to find out from the clinical trial. But I would say that I wouldn't, at this point, I would say don't do it. I would get more information.
Okay. Okay, so this one has it's a little bit of a long backstory. It says, my diagnosis was primary cutaneous anaplastic large cell lymphoma. I had a lesion on my knee in July of 2019 that was misdiagnosed. Another lesion appeared early July of this year, which was identical. My primary care physician immediately did a biopsy, which was sent from here in Florida to Mayo with a follow-up diagnosis of PCALCL. In everything I'm learning, it seems that this is something that is treatable, not curable. I am currently in electron beam radiation on my arm. Moving forward, do I just assume any new spot could yet be another one? I've had another biopsy since I began radiation on a new spot, which came back negative. And I can repeat any of that but I think it's just the main question is, do I just assume any new spot could yet be another one? So should she continue to have biopsies?
Yeah, I'll comment on this. I mean, this is a hard thing to deal with. You know, you find out that you've got this very rare problem, especially if it was initially misdiagnosed. You may be, kind of fearful about making sure that you get things captured in a timely fashion and get timely therapy as well. But I advise my patients to give new bumps and lumps and red spots a 3-week wait period. because I don't want patients to panic about every bug bite or ingrown hair that they develop. So most lesions, if they're inflammatory and benign, they're going to be on their way out after about a 3-week observation period. If you've got something that's fixed, that's either getting worse or clearly not going away after 3 weeks, that may warrant a biopsy. But I think the timeline or the chronology of any new spot is very helpful, so that you don't panic every time you get a benign lesion on your skin.
Okay. Let's see. Dr. David Louis mentioned that MF is not hereditary, but could be related to genes that control our immune system. What does that mean? And then it's side note, and by the way, my mother had MF for over 20 years now, and I have just been diagnosed with it. Let's see. Dr. DeSimone, do you want to take that one?
Sure, yeah, I'm happy to. So, we don't know exactly what causes CTCL, but we think that it's an epigenetic disorder, which means that it's partially part of how your immune system works, not a specific inherited mutation or anything like that, and partially what environmental exposures you've accumulated, usually over your lifetime. So I think, I'm not exactly sure what the other physician was getting at, but what I think they probably were trying to explain is that, certain people have certain strengths in terms of how well their immune system is able to control cell regulation and maybe knock out any abnormal cells before they're able to grow into a cancer. And some people have a little bit of a weaker function in that sphere. And speaking very, very generally, how your immune system functions and its strengths and weaknesses can to some degree be inherited. So I think that's probably what was being described. It is very unusual that both you and your mother have had the same disease. We can't exclude the fact that you likely had the same environmental exposures for many, many years of your life, and that may be equally in play here. So I hope that answers that. It's a tricky one.
It is. Anything to add, Dr. Fisher, Dr. Kim?
Yeah, I think that I just want to echo that we really don't know the cause of this disease. We haven't found any specific genetic component, a specific gene or anything that we can look for. We have seen multiple cases within a family, and as Dr. DeSimone mentions, is that just common exposure or is it genetics? And we don't really have the answer.
Mm-hmm. Okay, this next one is for you, Dr. Kim. Are there any studies being done on collateral damages, in parentheses, health, for CTCL patients?
So I think there are two aspects to that question, if I'm interpreting it correctly. What is known is that all cutaneous T-cell lymphoma patients with MF or LYP, remember early stage patients do very well with good prognosis, but one thing to kind of keep in the back of the mind for all MF patients is that there is a slightly increased risk of a second lymphoma. So that can be Hodgkin's lymphoma, that can be LYP and MF together in the same patient, it could be a B-cell lymphoma. So we do see that occasionally in our MF patients, and that's just an interesting association. So that is known, and I always counsel my patients when they're first diagnosed that they need to just keep an eye on things between visits and notify if there's anything that persists more than 3 weeks, or if they develop what we call B symptoms. In terms of other comorbidities, which may be what the question is alluding to, I mean, there are many skin rashes, like psoriasis, for instance, is the prototypical one that's been associated with increased risk of coronary artery disease and other types of, and stroke. And so, the question of whether MF is associated with other types of important medical diseases, we don't really know. To be honest, because MF, we have such small numbers of patients, so we don't have that good epidemiological data, unlike psoriasis, which affects so many more patients. So I guess the jury is out in terms of that.
Okay, let's see. My original diagnosis was 2B tumor stage with LCT. Since then, radiation cleared the tumor. I was on bexerotene for 2 years, and the last patch finally cleared a few months ago. How vigilant should I be given that the original diagnosis included LCT? Also, my doctor suggested potentially stopping bexerotene, although it was originally told to me that it would be a lifetime medication. Dr. DeSimone?
Sure, I'll take that. First of all, I'm glad to hear that you're getting better. That sounds like you've made a lot of progress there. I think that there are no uniform guidelines in terms of how long you should keep a patient on bexerotene, especially in the setting of achieving great disease control. And so I don't think that it's all that unusual, while I admit very frustrating, that you may get differing recommendations in terms of how long you should stay on that drug. How vigilant should you be? You should be following up with your CTCL physician at least twice, 3 times a year maybe, and just make sure that you're checking in frequently and surveilling for any changes or any recurrence of disease or worsening of disease.
Okay. Anything to add, anybody? No? Okay, let's see. Next one. I have read there is research occurring regarding the correlation between T cells and the severity and recovery from COVID. What significance would this have for MF patients? COVID, kind of a hot topic for everybody, I know. Anybody want to take this one, Dr. Fisher?
Yeah, I can take a stab. Certainly there are a number of immune reactions in play when patients are infected with COVID, and patients respond very differently to the virus that we've learned, different symptoms, different severity, and we're trying to learn more all the time. We've learned quite a bit in 6 months, but we've got a long way to go. How it affects the immune system is not entirely clear. There is a strong immune response, which varies from patient to patient. Whether that immune response is particularly helpful or maybe not is unclear. And looking at how much of that is T-cell driven, B-cell driven, we know, for example, that high-dose steroids can often help in patients' outcome that have severe COVID infection, and that's an immune suppressant. We're still learning how these all interplay.
Okay. Let's see. Anything to add, anybody? No? Okay. What therapies are appropriate for tumors with large cell transformation that don't express CD30?
Well, I guess most of those are going to be chemotherapy related, so I'll take that one. Okay. Brentuximab, which they're referring to, which is a conjugate that binds to CD30, is often used in large cell transformation because it is a type of CTCL that more commonly expresses CD30. We can even see responses when CD30 is negative, but certainly if it's positive, response rates are much higher. The percent involvement only needs to be very small. Only even a few percentage can correlate with response. So to keep that in mind. Other agents that we use are standard chemotherapy agents. We tend to use single agent chemotherapy, drugs like gemcitabine or liposomal doxorubicin. Pralatrexate has been approved specifically for cutaneous T-cell lymphoma. That's sort of a powerful methotrexate-like drug. Romidepsin has been approved also for CTCL. So there are a number of options, and the choice for each patient can be different depending on their other illnesses, their past therapies, etc.
Okay, great. Let's see. I also have lymphedema. How does this damage to lymphatic system impact my stage 2B cutaneous lymphoma? Dr. DeSimone, do you want to take this one?
Sure. I apologize for some background noise if you hear it. I think I would just speak generally here because there isn't an exact correlation that has been well documented. But in general, the way that your body heals anything is to send inflammatory cells to the site and then remove those inflammatory cells, briskly, and that's a critical part of the immune response to anything going on in the skin. And if you've got lymphedema, meaning that your lymphatic flow is significantly impaired, I would imagine that process is also slowed. So I think that it certainly could contribute to making things look worse or feel worse. I don't think that pathophysiology, it could pathophysiologically it could trigger any progression of disease specifically, but I think just the fact that when you've got impaired lymphatic flow, you've got impaired wound healing in general, that could be a problem.
Okay. Let's see. Are there any genetic tests or genomic profile testing that a CTCL patient could get to learn more about their genes?
So you're keeping up with the research, it looks like. So I would say that definitely in the research arena, many groups have and are continuing to look at gene profile or genomic studies, both in the skin and in the blood of cutaneous lymphoma patients. And that is an area of extremely active research. And of course, the goal is to try to identify which genes, when they're expressed or downregulated, what that means for overall prognosis and what it means for what treatments would work for you. Whether right now it's not really being used at the clinical level, so patients who come in don't necessarily have that done automatically. I can tell you at Penn, when we do it, we tend to do it in the setting of patients who may need to try other therapies because they've sort of gone through the standard therapies. So many cancer centers do offer that testing for the tissue when we're trying to look for another approach. I guess I wanted to put a plug in because this is such an important, exciting area that many specialty centers, they may approach you and say, are you willing to participate in research by donating skin biopsy, an extra skin biopsy or blood work, a tube of blood? And I would absolutely encourage you to think about doing so, because that is incredibly important for our overall goal in learning about this disease better, trying to come up with better therapies, maybe even a cure someday. So I know many of you have already done so, and thank you. I think our community is so good about that, but those, we sometimes call it tissue bank studies, are incredibly important.
Mm-hmm. Great, thank you. I have stage 4A Sezary Syndrome. Are there any integrated alternative methods of treatment to add to conventional treatments? Maybe Dr. DeSimone or Dr. Fisher, maybe both of you may have something for this one.
I'll defer to Dr. Fisher on that.
Okay.
Yeah, as far as standard therapies for Sezary syndrome, there's 3 drugs that we primarily use, romidepsin, mogamulizumab, and Campath. The latter 2 are directed at specific target of proteins on the surface. Is there anything that you can use to complement that, I think is the question. I haven't really found things that are labeled, quote, alternative medicine that have had direct effect against CTCL. There's a number of things that may be able to help, certainly with side effects, including pruritus or even therapy-related complications such as nausea, etc. CBD oil can certainly help with nausea. People find acupuncture and massage helpful. But as far as a direct effect against CTCL and Sezary syndrome, the 3 agents that I mentioned are sort of the primary focus.
Okay, so this one is a little bit of a backstory. Their main question is they would like to know if their disease is progressing, but she said, I have only had papules and no plaques or patches. The last biopsy was CD4 positive, CD8 positive, and partial CD7. I've been on low-dose methotrexate oral and daily prednisone 5 milligrams since last fall. Recently, my skin has started turning red and it's burning. My dermatologists have never staged me since CD30 LPD diagnosed in 2016, but I've had papules since 2005. And then she said, is my disease progressing? And I can reread any of that if...
I think it's very hard to give you an answer to that in this format. I think you definitely need to go to the physician that is caring for you and get a new exam, discuss perhaps the role for any further workup. But any worsening in your skin findings absolutely needs to be addressed in a timely fashion. It's just very hard to tell you what's going on from a verbal description.
Okay. Let's see. I'm 29 with early stage MF, and I know there are other young people who have participated in the conference. Is there any difference in progression or prognosis based on age at diagnosis? That's a good question.
That's a good question. Yeah, that's a common question. So the answer is younger patients, and that's defined as less than age 30 at time of diagnosis. If you control for stage of disease at diagnosis, they certainly don't do worse than the average patient diagnosed at age 50 to 60. And if anything, they may do a little bit better in terms of disease progression, which is sort of counterintuitive because I think many of my young patients often worry that if they're diagnosed at age 20, they have so much longer to live with the disease. So there's a higher chance of progression. But at the basic level, there is no, the rates are not higher. The thing that we have to watch out for younger patients is that we have to just be a little bit careful about the long-term side effects of certain medications. So because you live longer with the disease. So the one that's most common and most relevant is phototherapy. And phototherapy is a godsend for many patients. But remember, phototherapy also is just like concentrated sun. So if you have many, many, many years of uninterrupted treatment, and depending on your skin type, if you're very fair, then there could be issues with sun damage and skin cancer. So as physicians, when we kind of oversee your treatment, we for a young MF patient, we want to give you breaks from phototherapy. And so, you know, but in general, being young and being diagnosed with this, it's not worse prognosis.
And just a heads up here, we have about 5 minutes left, so we probably have time for about 2 or 3 more questions. After radiation treatment of MF1A, will it return again?
I can take that one. So local radiation for limited, 1A MF has been shown to provide good, long-lasting, durable responses. It's still not technically considered a cure, but many studies have documented durable results lasting, 8 years, 10 years. So it's a pretty long-lasting therapy, but it's not a cure, unfortunately.
Let's see. I read Dana Farber has been conducting CAR T-cell immunotherapy using altered T cells to target cancer cells. If my son's T cells are the cancer, are there other immunotherapies being studied for MF? Dr. DeSimone, I see you nodding.
Yeah. I'll start, but then I'm sure that Drs. Kim and Fisher might have more to add. But basically, yeah, it is very tricky because when we're talking about manipulating our healthy T cells to fight a cancer, we can run into problems if that cancer is also a T cell based malignancy. So that's a problem with CAR T. It can be a problem with a class of immunotherapy called PD-1 inhibitors, which basically disinhibit your healthy T cells so that they can better identify and attack a cancer, but some studies have shown that you can, by using those drugs, further disinhibit some of the malignant T cells as well. So it certainly is tricky, but that said, there are many ongoing trials looking at systemic infused immunotherapies in the treatment of MF and Sezary Syndrome. We also have some topical immunotherapies, specifically topical imiquimod, which has shown some really positive results. The way that it works is it kind of enhances your anti-tumor proteins in your skin and kind of helps wake up your healthy immune cells in your skin to better identify and attack atypical or malignant cells that may be there. So I think that's probably the best answer that I have for that, but I welcome the input from Drs. Kim and Fisher.
I can just comment on the CAR T component. A lot of patients do ask about that. They figure, sounds like something for T cell therapy, but what it is, it's actually placing a gene into your T cell to help it recognize a B cell lymphoma. Unfortunately, we don't have that technology developed for attacking T cell lymphomas. The difficulty is you can knock out B cells and do fairly well, but living without T cells, your healthy T cells, is impossible. So we have to find a way of targeting the malignant ones and saving the healthy ones. And I suspect someday that will happen, but we don't have that quite yet. So we have to look at other ways of using immune response. Dr. DeSimone mentioned PD-1 immunotherapy does have activity in CTCL, but also sometimes can trigger the disease, so you have to be very careful. The ultimate immune therapy that we have for this disease for advanced stage patients is donor stem cell transplant, essentially giving the patient a new immune system to attack the disease. And in the right setting, that can be very useful.
Okay, let's see. All right, so our last question. Have there been any side effects with long-term use of Valchlor? Dr. Kim?
Well, Valchlor, which is nitrogen mustard gel, has a really, really long history. And before Valchlor gel, there were compounded mechlorethamine nitrogen mustard ointment. And before that, there was the solution. So it's been around a really long time. And the study, the safety profile has been studied for a long time. So I guess, number one, it's not absorbed internally. So that's good, even if you put it all over your body. And number two, in terms of, sort of overall side effects, the main side effects are a 20% risk of an itchy, irritant, or allergic rash that is reversible if you stop the medicine and use topical steroids. You do have to take some precautions though, so you want to make sure that you don't get it in your eyes or mouth or near too close to the sensitive areas of the skin. And then I guess the other safety issue that's sort of interesting was there was some concern of skin cancer risk, using it for a long period of time because it's an alkylating agent. But they've done many, many studies, most notably from Scandinavia, that there does not seem to be an increased risk of skin cancer using topical nitrogen mustard, and that would apply to Valchlor gel as well.
Okay, anything to add, anybody? No? Awesome. Well, this does conclude the Q&A portion, and thank you to Dr. Kasamon, Dr. DeSimone, Dr. Fisher, and Dr. Kim. We're so grateful for your time. Thanks for spending your afternoon with us. We're so appreciative. So everybody, thank you for joining us, and we apologize if we didn't get to your question. There were a lot of them, so we cranked through what we could, and thanks for being here. And I'm going to turn things back over to Susan to wrap us up.
Great, thanks. Thanks, everybody. And yeah, I really appreciate everybody's taking their time today to join us. And thanks for all your phenomenal questions. We're going to look at a way to capture those that didn't get answered, I think, and see if we can do some follow-up. Some of them are similar, so they run in kind of same kind of questions. So we'll see if we can categorize them and get back to everybody. Give us a little time to do that, but we're going to do our best to try to get everybody's questions answered. You asked some really terrific ones, and we're going to try not to leave any of you still with questions. But if you do have questions, Hillary's working on, we do open Q&A webinars every quarter, and I think
Next month. Next month will be the next one.
So we'll have another open Q&A next month with, I don't know who's joining us, but we'll have
far it'll be Dr. Frank Glass, and we'll have another panelist with us as well. So if you have outstanding questions, please come with them.
Yeah, so, we're trying to do these kinds of open Q&As more often and online so that you'll have access to experts in the field that can answer and address to the best of everybody's ability. So again, let's see. And I don't know, Hill, there's probably no way at this point to let people turn their cameras on or anything. Just
no, unfortunately not in the webinar.
Last time. I was hoping we'd be able to, we're learning technology, everybody. So please bear with us. I was hoping to be able to say goodbye to everybody, like in the screen that we had with everybody's videos turned on and all, but sadly, we're not able to do that. We'll figure that out for next time. But I hope everybody was able to listen and watch the other presentations. We're going to have, the whole program will be open through Sunday. So you can go back and watch any of the videos again, or ones that you missed, especially for you folks maybe coming in from a different time zone. It was too early in the morning. So you can go back and watch at your leisure at any time over the weekend. And then we'll have the presentations posted on the website. Give us about a week to get those up, just like we do normally. So you will always have access to the presentations on demand going forward. And I really wanted to say thanks to everybody for joining us last night, especially to Sabrina. I know your story really touched a lot of people, and it takes courage to share your experience, and it goes a long, long way. And we had some great discussions in our breakout session. I'm sure there were fabulous discussions in the other group, and we got some great ideas of ways that we could better serve folks that are maybe younger, that have different kinds of questions, and connect people in ways. I'm really excited about the capacity now to use technology to connect us, because we can't always, as a small organization, and there's not a lot of us in any one geography, it's sometimes hard to get together physically, and now we can't because of the impact of COVID. But I think combining in the future the online technology to connect everybody in a more frequent way, and maybe with different subgroups, will be a possibility. And I would also encourage everybody, if you haven't joined our new online cutaneous lymphoma community, I really encourage you to do so. It's a private online way. It's password protected for patients and family members. We've got several different groups already set up there. So the MF group, the Sezary group, we've got an LYP group. And we have a B-cell group, cutaneous B-cell. We can certainly establish, a young adult group. So it's really a great online way for people to connect every day, and in a safe environment. You don't have to worry about being exposed, to outside forces and things like that. And then we have a knowledge base on there. So there's all kinds of great information, and we would love to have your feedback on the community so that we can enhance it and do more things. I have lots of ideas about how to bring more to your fingertips, but we really would love to hear from you. What would be most beneficial, and what would you like to see us do? Because that's really why we're here, is to serve you and to help you. I always have to quote Oprah, but live your best life, right? Because that's what we want to do, and live beyond our cutaneous lymphoma. It just happens to be something that we have to deal with, but how do we live life on our own terms otherwise? So lots of great things. I have lots of takeaways, and I also want to encourage, we're launching tomorrow our Get Your Move On fundraising and awareness event. So Tuesday, September 15th is World Lymphoma Awareness Day. So globally, we'll be participating with all the other lymphoma groups around the world to raise awareness about lymphomas in general. And we can raise awareness about cutaneous lymphomas. And I encourage you to get involved. You can find more information on our website. I'm really excited. Thanks everybody who's already joined up with a team or as an individual person. I'm making the commitment to move in some way every day for the whole program. So that's beginning tomorrow and through next Saturday. And then we're going to have a fun ceremony, awards completion ceremony on September 22nd. So I look forward to seeing you all there. Let's stay healthy, stay well. I can't wait to see everybody in person, hopefully sometime next year. And in the meantime, we'll get together on formats like this so we can all connect and stay engaged and learn and live our best life, right? So thank you all so much. Have a great rest of your weekend. Thanks for joining us. And I look forward to seeing you somewhere, whether it's online and someday in person. And to our friends to the north in Canada, we're going to do some more great things there. And for anybody that's joining us outside of the US and Europe, we've got some great plans there as well. So know that we're doing our best to take you with us wherever we go and to bring back all the information that you need to live well, and even though you might have a diagnosis of cutaneous lymphoma. So have a great rest of your Saturday, a great rest of your weekend, and we'll see you all soon. Thanks, everybody, and thanks for my incredible team and our board members that joined us and our corporate sponsors and our donors. We can't do this stuff without your help. So thank you so much, and we'll see you all soon. Take good care. Have a good weekend. Bye-bye.